I'm just going to give a brief summary in terms of community support for people living with diabetes. And most in my talk, it will sort of reflect the encounter, the experience that I have with working in Tower Hamlets retinal screening program. So why do we need to move towards a community-based approach? Well, looking at what we have encountered this morning, it looks like community, there's quite a lot of discussion in terms of sense of belonging and integration, shared aspirations, experience, values, and beliefs from what was being discussed this morning. Fulfillment of own potentials in life, regardless of the condition, promoting personal and social responsibility for our patients whilst they are living in their own community. And also, hopefully, there's a sense of mutual commitments and obligations, not just from the patient's perspective, but also for healthcare professionals. There's quite a lot of discussion in literature in terms of what works, what doesn't work. But for what we have as documented by the National Institute of Clinical Excellence, we have the chronic care model, which is currently in use in England. The framework of care for people with long-term conditions such as diabetes. And generally, there is an acknowledgement that substantial chronic conditions such as diabetes, they are far much effective in managing them outside formal healthcare settings such as hospitals. There are several elements that feeds into this framework, 6 of them, but of interest, one of the key elements is that community resources such as health education and health promotion programs and patient self-management. And also, this particular model, it identifies critically the importance of healthcare professionals engaging with those people living with diabetes, and hopefully then have some form of equal partnership with their multidisciplinary team members. Another model we also have that is practically being driven in various areas across England. We've got the primary retinal screening program, which are more community-based at primary level. This came up by documentation from the National Safe Framework for Diabetes as part of their delivery strategy in 2003. Something that you are quite familiar with, GPs is their responsibility to make appropriate referral to this screening program. And the main aim of the national screening program is to identify sight-threatening disease in a timely order and then make appropriate referral. By just the show of raising of hands, can I just ask who have had retinal screening in the last 12 months? Okay. In the last 6 months? Yesterday? No? So the screening program, they run at different level in different settings. Some, like the one I'm going to talk about, is fixed at a particular location that is linked to other multidisciplinary team members in form of diabetes nurse specialists and health educators. This gives an advantage for screeners to have that collaborative networking with various professionals who are more effectively involved in the management of diabetes. And at primary level, the biggest advantage with this community-based model is a one-stop model. As patients attend their health education classes, health promotion classes, there's an opportunity for them to get their eyes checked. And there are reasonable waiting times compared to eye clinics. So something that you are quite familiar with, there's the initial assessment and eye drops installation, which is not quite popular with some. And the fundus photograph system is carried out by either the nurse, optometrists, or technicians. And image graders, those who have gone under extensive training and signing off, will subsequently look at those images for evidence of active diabetic retinopathy lesions. This form of model is quite opportunistic as well, in the sense that there are certain non-diabetic related lesions that can also be identified during retinal screening. These are like cataracts, glycomatous discs, and macular degeneration. And upon identification of these non-related diabetic eye disease lesions, appropriate referrals will be made to the appropriate disciplines. We've also experienced that there's been quite an interesting and amazing technological advancement, such that some screening programs are quite well equipped with certain equipment that gives detailed information through scanning the retinal image. So through this form of technological advancement, there will be even more effective and robust patient pathway by making sure that patients are referred on time to different clinical areas. So there's clinical support from the program lead, who is responsible for training all the image graders. In this afternoon, we are privileged. We are doing that with Dr. Tunde Petro. There's also defined patient pathway that we follow, that has come up from the National Screening Committee, and there's also clinical guidelines that are sort of driven at every local level. Something that you're familiar already, for straightforward retinal photography, when there's no evidence of diabetic eye disease, our responsibility is to then congratulate the actual person and bring them back in 12 months. But however, there are also situations where we have to make that judgment in terms of diabetic eye related complications. So where there's some form of complications, which could be leakage or growth of abnormal blood vessels, we do have to make appropriate referral to eye clinics where ophthalmologists, they will do further investigations. So the transition from primary to secondary, so what does it actually, what are the systems that are there in place? So sight-threatening disease is correctly identified at the time of screening by graders. Referral is made to eye clinics, as I said. For evidence of non-diabetic related features, they will be made to various subspecialties in ophthalmology, which can range from glaucoma service, cataract, or macular degeneration clinics. For those patients who don't necessarily need to to be referred to eye clinics, we see them back on annual basis as recommended by the National Screening Committee. It's also quite opportunistic that we are able to sort of deliver opportunistic health promotion. By the time you get your eye drops instilled, by the time we get to do the photographs, whether there's any concern or any control to do with your diabetes, we can offer that level of support in terms of health promotion, which can range from psychological and emotional. But at Myland, we are quite privileged that we do have a wide reach multidisciplinary team setting where we can make instant referral. And also just to sort of highlight that retinal screeners and opticians in High Street, we've got complementary roles. As well as seeing retinal screeners, you also need to keep up to date with your local optician to get your glasses checked as necessary. So once you get to that level where you have where you've been referred for treatment at secondary level, doesn't necessarily mean that that's the end of it. There is an opportunity in form of treatment. Investigations, they have to be carried out in deciding what kind of treatment can be offered. And then treatment is offered in most cases at secondary level. We've seen quite a lot of experience and evidence that there's striking evidence that most of these treatments in relation to diabetic eye disease, they're effective, they're quite safe, and there's also quite different treatments that are now emerging on the market. Once there's response to treatment, that's also a sign or a good opportunity in terms of good diabetes control. Once there's an indication of this disease stability, we discuss that in partnership with the patient. And the fact that one has been referred for management in eye clinics, it doesn't necessarily mean that they'll stay in the eye clinics forever, but there's an opportunity for them at certain level to get them referred back to screening where they came from. So at that level, that's when we make that clinical decision in terms of discharging back again to primary level. There's been quite a lot of huge discussion in terms of health promotion and health education, what has been documented in the literature and what we experience in clinical setting. But most of these, they are driven by people living with the condition diabetes mellitus. We've seen the introduction or the discussion around the expert patient program that came up from the National Institute of Clinical Excellence, mainly based on the fact that people with diabetes, they are best people, they are the experts in managing their condition. They're better off, they understand it much far better compared to healthcare professionals. And I was discussing earlier on about referral to secondary care, but there's also striking evidence in literature on the importance of keeping blood pressure and blood sugar under control, even at that level where you are having course of treatment at secondary level. There are several programs that are out there in the community from what we've experienced. The DEFNI program, has anyone heard about the DEFNI program? Yes, by the rise of hands, yeah? Including our 2 colleagues in the front. And the Desmond program? Excellent. And I think these are run at different levels in different, primary care trusts across the country. But mainly they are therefore to support the DEFNI program people with type 1 in terms of lifestyle intervention, health eating, blood glucose monitoring, and so forth. There's also quite a huge discussion in terms of integrated multidisciplinary team approach. What we experienced this morning were different members of the multidisciplinary team coming to discuss with us about their experience, their roles in terms of managing this condition. But far and far most, the GPs, there's been quite a huge discussion. They are centralized, they've got the information, they've got such a huge responsibility in managing this. But there are also times when we see you in different settings where we probably feel that we need to communicate with your local physicians in different settings, and we then make that appropriate referral to sort of discuss or get some further investigations in terms of your diabetes management. Health promotion and health education classes in most settings, they are driven by people with diabetes themselves. Diabetes UK representation, they exert such an amazing force in terms of ensuring that awareness and living the condition is raised. Counselors and emotional support, the role that is played by Mr. Martin Adiebo in relation to diabetes, what he discussed this morning. So in summary, people with diabetes mellitus, they play a significant role in managing their own condition. They spend more time with various healthcare professionals, specialists in food, specialists in this and all that, compared to those of the general population. Diabetes mellitus is such a complex disease, multi-system disease, and we encourage everyone that their attendance to various appointments is critical. Health promotion and health education offers multiple opportunities in reducing complications. Regular eye checks are very important, and chronic community care, the model that I discussed earlier, it puts patients at the center and gives them their responsibility in managing their condition. Thank you very much for listening.